Spinal injections for low back pain. What's the evidence? Everyone was shocked to learn that in 2012 and 13 there were 55 deaths nationwide due to meningitis following spinal injections for pain. The identified cause was a fungus, a common black mold found primarily in plants. Unfortunately, fungal infections are very difficult to treat, involving medications that are sometimes ineffective and often very toxic. The problem here is inadequate quality control and oversight with a production practice called pharmaceutical compounding, which is defined as, quote, preparation, mixing, assembling, packaging, and labeling of a drug or device in accordance with a licensed practitioner's prescription, unquote. And although the original intention was for individual pharmacists to customize medications to meet each individual patient's needs, greed and expediency took over to bend the rules and allow large-scale production of a single medication divided into smaller amounts for individual need without governmental oversight and monitoring. Making the dilemma even more alarming and illogical is that 52% of deaths occurred in one state, Michigan, with still yet no plausible explanation. Although the question here is clearly one of quality control, this tragedy shines the spotlight on the therapy itself, calling into question the risk-benefit ratio, and therefore implies the need for a search into the literature for studies supporting or not supporting its use. A recent publication in 2013 in the Journal of the American Medical Association analyzes and criticizes the practice of spinal injection in Spinal Injection Therapy for Low Back Pain by Stahl et al. The author's conclusions were, quote, given the weak scientific evidence base and the availability of non-invasive and more effective alternatives, physicians and policymakers should not recommend the use of injection therapy for patients with low back pain and sciatica, unquote. But let's look a little deeper into what a scientific investigation into this therapeutic approach involves and the different questions that need to be asked, studied, and analyzed. The problem with spinal injections as a general category is heterogeneity. There are first a number of different substances injected alone and in combination, including corticosteroids, local anesthetics, NSAIDs, morphine, and others. And also a number of different target tissues, including facet joints, the epidural space, IVDs, ligaments, muscles, or trigger points. There are two main types of spinal injections reviewed in most studies. Epidurals, which involve anesthetics or corticosteroids, or a combination of both, and muscle and trigger point injections, which involve usually anesthetics or B12 injection. So let's focus first on epidurals. This involves injection into what is called the epidural space. What is the epidural space? It's also known as the extradural or peridural space, and it's the space between the dura and bone that contains lymphatics, the spinal nerve roots, loose fatty tissue, small arteries, and the epidural venous plexus. There are several types of epidural steroid injections, or ESIs. This includes caudal, interlaminar, also known as translaminar, and transforaminal, also known as selective nerve root injection or block. These are further classified as nonspecific or specific. Caudal and interlaminar are known as nonspecific because there is no fluoroscopic guidance, also considered a blind approach. Transforaminal are considered specific because of the fluoroscopic guidance. Now, let's approach the topic from a pragmatic perspective and ask some key questions before interpreting the literature on this topic. The most important question is which patient group is this intended for, and what are the results in each of these groups separately? Second, we want to know the intended outcome. In other words, is it to cure the problem, or is there another use for the injections distinct from cure, and what is the literature opinion for this, separate from cure? Let's start with patient type. Is this treatment intended for acute, subacute, or chronic low back pain without radiation, or is this for a patient with radicular findings? If we look at the most recent Cochrane review on the subject, we find a limited focus. The review is entitled Injection Therapy for Subacute and Chronic Low Back Pain, an updated Cochrane review. Their conclusion was, quote, insufficient evidence to support the use of injection therapy for subacute and chronic low back pain, unquote. In this Cochrane review from 2009, only 1/3 of trials demonstrated significant results for at least one outcome, pain, disability, or general health status, compared to another treatment approach, and only 4 studies reported effects that reflected clinically important changes. What about international guidelines? Well, only Belgium recommends injection therapy. Guidelines from the United States, Europe, Italy, and the United Kingdom do not recommend injection therapy, but specifically for chronic low back pain. Also remember that guidelines are interpretations of the literature plus expert opinion, so that the scientific rigor is not always equal across guidelines and is influenced by the healthcare system structure and politics of that country. Generally, guidelines recommend education about low back pain, NSAIDs, opioid analgesics, exercises, spinal manipulative therapy, multidisciplinary rehabilitation, and behavioral therapy prior to injection therapy or surgery. Hard to argue with and certainly literature-based. Looking at the limited number of randomized controlled trials for spinal injections, some generalized findings do emerge. When compared to placebo injection, there appears to be little difference regardless of technique when measured over time. In other words, any differences diminish over periods of 1 to 2 years. ESIs for low back pain only have not been shown to have any short-term or long-term benefit with regard to low back pain. ESIs for radicular pain, especially using transforaminal injections, seem to demonstrate at least short-term benefit better than placebo. Let's look a little closer at some more specific examples of injection sites, patients, and uses. One prospective descriptive study evaluated the injection type and the percentage effectiveness based on where the injection was given in 60 patients. Remember, the outcome here was prolonged pain relief. Here are the numbers. For caudal, 55.9% reported relief. For lumbar injections, 78.5%. In facet injections, only 28%. And in SI injections, only 10%. Now, let's focus specifically on the patient population that is often refractory to standard conservative approaches, the patient with radicular pain. In a recent study in Pain Physician, entitled Effectiveness of Therapeutic Lumbar Transforaminal Epidural Steroid Injections in Managing Lumbar Spinal Pain, the researchers concluded that transforaminal ESI was good for radiculitis secondary to disc herniation, fair for radiculitis secondary to spinal stenosis with local anesthetic and steroid, and limited for axial pain, meaning low back pain only, and post-surgery syndrome with local anesthetic with or without steroids. So now a very important distinction. What's the intention of the treatment? Is the sole intention to cure the patient of pain, or can there be palliative approaches that have value? We've already discussed some of the literature evidence for a curative approach demonstrating some limited results that seem to favor the radicular patient who's failed conservative care. Now let's look at the rationale for using epidurals, facets, or SI injections other than for cure. For example, if used as a palliative, injection with steroid or anesthetic may decrease pain and muscle spasm and allow further therapy or even prevent surgery. Representative of similar small studies, a publication in the Journal of Bone and Joint Surgery entitled Nerve Root Blocks in the Treatment of Lumbar Radicular Pain, a Minimum 5-Year Follow-Up, reported that from an original previous study, 71% of patients with selective nerve root block avoided surgery at 16-month follow-up. This follow-up study indicated that at 5 years post-treatment, the effect was maintained. Another common example of a palliative use that allows other therapy approaches is providing a window of opportunity for manipulation. It has now become fairly common in some multidisciplinary practices to use spinal injections to relieve pain and muscle spasm, enough so that the patient can then be manipulated, whereas previously they could not be positioned without pain. So wouldn't all of these non-curative, more palliative approaches have value if placed appropriately in the decision stream of ongoing care for patients that are non-responsive to general conservative care prior to sending them for surgical consult? In fact, by taking all of what we have just discussed, it may be possible to design an approach to decision-making that suggests when and where spinal injections are a reasonable and rational option. Let's follow this thinking logically through a simplified algorithm. Initially, for patients with low back pain with or without radiculopathy, use a conservative, non-injection, non-surgical approach, which should be successful for most patients. If unsuccessful, or the patient is requesting surgery, consider referral for injection to either allow manipulation in those unable to be positioned without pain, and or for those with radiculopathy, hopefully potentially preventing the need for surgery and allow time for natural healing to occur. Well, now we've come full circle from therapeutic effect to a patient's decision based on the risks, the risk-benefit ratio that always must be considered with any therapy. Of course, the recent meningitis concern is a serious issue, but has more to do with the preparation and distribution of the drug. Let's look at the procedure itself and the literature estimate of the different associated risks. This recent study outlines some of these in a review entitled The Risks of Epidural and Transforaminal Steroid Injections in the Spine, Commentary and Comprehensive Review of the Literature by Epstein in 2013. He concludes that, quote, the multitude of risks attributed to these injections outweighs the benefits, unquote. So let's look at these. He reported the following conditions, rates, and ranges based on the literature. Spinal fluid leaks occurred in 0.4 to 6% of patients, positional headache in 28%, adhesive arachnoiditis in 6 to 16%, and allergic reactions, hydrocephalus, air embolism, urinary retention, and intravascular injection in 7.9 to 11.6%. Interestingly, in only about 1/3 of interlaminar injections does the agent actually reach the ventral epidural space, the target area. Also, with caudal and transforaminal ESIs, 11% of the time, the agent is injected into the bloodstream, and in 2% of interlaminar ESIs. Dural puncture is highest with interlaminar ESIs at 5%. So averaged out, it's likely that about 5 to 10% of the time, there'll be some type of issue developing as a result of an epidural injection. Also, the rate is different based on approach. Adverse events occur in between 5.5 to 9.6% of transforaminal injections and 15.6% for caudal injections. Certainly, patients must be made aware of this before consenting to treatment. Clearly a complex topic, but hopefully we've separated out several factors. Don't confuse the issue of the risk-benefit decision with a separate issue of an isolated contaminated compounding site. Don't assume that injection is suggested for all patients with low back pain, but that injection limited to those who are refractory to other types of conservative care might seem reasonable if the patient is willing to accept the risks. For those with radiculopathy versus those without neurological involvement, injection has been shown to have some potential benefit, including in some studies, avoidance of surgery. And finally, injection may allow a window of opportunity for chiropractors to perform a trial of manipulation. Worth your consideration.